Hey folks, Premier Tim Houston here. Wear Red Canada Day is celebrated annually across Canada on February 13th to raise awareness about women's cardiovascular health. The Canadian Women's Heart Health Alliance, comprised of over 120 women's heart health professionals, patients, and scientists from across Canada, established the National Wear Red Canada Day in 2019 as an awareness campaign with the ultimate goal of improving heart health of women in Canada. Wear Red Day in Canada actually originated in Nova Scotia in February 2018 in recognition of the Alliance's hard work and the importance of women's health. I'm proud that we proclaim February 13th as Wear Red Canada Day in Nova Scotia, and I'll read that proclamation now. Whereas heart disease is the #1 killer of women worldwide and the leading cause of premature death for Canadian women, a fact unknown to many women and their healthcare professionals, and whereas Canadian Women's Heart Health Alliance is an organization of volunteer health professionals and patients working hard to improve women's heart health, and whereas Wear Red Canada Day is celebrated annually to raise awareness for all Canadians, but especially Canadian women, to be mindful, curious, and proactive in management of their health, their heart health and wellness, and whereas we want to see better prevention, diagnosis, and care, and fewer women dying prematurely from heart disease, therefore, I, Tim Houston, Premier, do hereby proclaim February 13th, 2024, Wear Red Canada Day in Nova Scotia, Canada.
Wear Red Day is such a significant day in Nova Scotia as it was born here at the QE2 Health Sciences Centre, thanks to Dr. Sharon Mulvey and team, and we are thrilled to see it now as a national initiative. And of course, Wear Red Day brings us together to support one another and learn about heart disease, #1 cause of death for women worldwide. We need to change that statistic. We now have world-leading cardiology teams focused on women's heart health across this country. We're extremely fortunate to have a women's heart health clinic here at the QE2 Center, a great source of pride for all of us. We hope that by participating in Wear Red Canada Day, you feel inspired by our guest speakers and empowered to improve your own heart health or perhaps the heart health of someone. Thank you for your support and enjoy it.
Really appreciate the support of the Nova Scotia Health, and we wouldn't be able to be doing this without them. So I think you know that, as Eileen mentioned too, we did start it here in 2018. And you know, many of you were maybe in the pictures, as you can see here, and I kind of did it chronologically over here from the left going over to the right. And you can see that we have had the big snow in 2019. And thank you to the weather gods that it's staved off a little bit this afternoon so that we didn't have that challenge again this time. And then, of course, we pivoted to the virtual webinars format during the COVID era. And that was in 2021 and 2022. And we did some really fun things. Like we had Andy Hay do a demo of a healthy chicken bowl salad that was excellent, and Angela Dufour, who's a lipid dietitian, she went on a shopping trip for heart healthy food. So you know, we tried to be creative, but now we're just back together in person again, and it's really fun. And this was last year, and that's this other side of the stairwell was under construction, as you might recall, and now it's all fixed up nice. So we'll hopefully do two sides. A little bit about the Canadian Women's Heart Health Alliance. I think that you're all aware of this organization that really is a grassroots organization that we established in 2018, involving professionals and women with lived experience from across the country, with this common mission to be able to improve cardiovascular health for women, recognizing that the signals were there that things were not quite right, and that women were having an inordinate number of situations where they were being misdiagnosed or not having the diagnosis and being sent away. And this is not just a Canadian issue, it's a global issue, really. And so our mission was really to be able to develop evidence and then to be able to make that evidence into opportunities that we would be able to actually guideline directed care for women, and this would change outcomes going forward. And we have had some successes, I think. As you can see here, nationally, the campaign has been in in existence for 6 years. And last year we had 49 proclamations across the country. We still want to get the big guy at the top or the big woman at the top, if that ever happens one day, to make a proclamation for the entire nation. But one day we'll get there. And we also light up buildings in red. So hopefully, if there's not too much snow tonight, we'll see that there are some lit up buildings. And I'll show you some examples, certainly in our region that we've done. As well as social media has been a big part of sharing this information and media interviews. The opportunity to be on TV, Atlantic television, Atlantic CTV rather this evening, along with Jan Coburn, one of our women with lived experience, who's also on the Alliance and did a quick action for segment for them. Maybe some of you saw it on the evening news last night. And then virtual movement. I would encourage you all to go online and to enroll in the movement challenge, which is open from 13th to the end of February. And it's really collectively to be able to do good things by activity for your heart. And then we have a national webinar that follows this programming locally here at 1:15 until 2:30 this afternoon. We will be broadcasting it here, or you can go to your own or whatever it is, your phone, whatever, and be able to look at that as well, because it wraps up the 9th chapter of an atlas that we developed of this evidence-based information about heart disease in women. Too much information to discuss in a short period of time, but we really have been very successful in getting information out there. And I think that is what's going to make the change going forward. Also we've reached out to high schools, and there's modules that are for learning in the curriculum of high schools to be able to, the younger that we become more aware, children live what they learn, right? And the sooner we understand about cardiovascular disease and how to prevent it, the bigger impact we're going to have. And that's, you know, across the board, men, women, and everyone. So, and then the key messages, we've been very sensitive culturally as well to translate our key messages into 14 different languages, and those are all available too. So these are just an example of some of the proclamations across the country in the last number of years. Examples of Wear Red Canada Day buildings, you can see from BC to Alberta, Quebec, Ontario, Manitoba, and highlighted Nova Scotia, there's City Hall, Albany Landing, Province House. This is actually beautiful. Peggy took these pictures last year, and Albany Landing was absolutely spectacular in red, doesn't it? I just, because probably some of you go there and it doesn't look as pretty, maybe, but it's how it can look so pretty. And then, you know, media is important, and actually we've had the opportunity as well during the COVID era. We did webinars. Misha Grossman joined us, who's a famous Canadian opera singer who is she lives just down the road. And Lori Kane, who is a famous ladies professional golfers and a wonderful ambassador for physical activity and athletics, particularly for young women. So we really support that. Here's Andy and Angela and the other webinar that we did. And so the thing is, we learned how to leverage virtual information in the COVID era, didn't we? And so we could broaden our reach. And again, welcome everyone who's joining us virtually today too. So this is really important that we can do hybrid events. And this is again to join us this afternoon. And all these resources are online. We're at Canada.ca and the Canadian Women's Heart Health Alliance. It's a wealth of information. So why the heck are we doing this? I kind of refers to that a little bit. We need to be able to increase awareness because we know that heart disease is a significant, heart and stroke, cardiovascular disease is a significant problem for women in particular that was kind of flying under the radar and wasn't fully being recognized. So in that vein, I want to try to personalize this a little bit more. And I would like to very much welcome to our event today, Shannon Sparnagle. And Shannon is a patient of mine, and her mother became a patient because she asked if her mother could become a patient. And I actually, I've only done a virtual consult with her mom. I'm going to do an in-person one very soon. But Shannon, please come and join us and share your story with us.
Thank you. And this set of numbers that I know. I'm Shannon Sponigal. I'm so happy to be here. I feel really moved to be here today, actually, and thank you, Sharon, and to the committee for inviting me to talk. And I'm so sorry, my poor mom's not here. She just got sick this morning, and she was halfway here from Pictou County, and I was on the road from Lunenburg, and she called and told me she was sick, and she said, "I'm wearing red, and I even did my hair." So anyway, I will speak on her behalf and do my best. And thank you for joining us, and thank you for everyone who's joining us virtually. Special hello to the folks at the Second Story Women's Center in Lunenburg, where I live. So I'll start with a little bit about my mom's story, and it's actually hard to think of how to condense it, because my mom had her first of 4 heart attacks almost 2 years ago, and she was only 49 years old. She was 49, she looked 30. She was slim and active and youthful. She was a high school teacher and skied, and she had no idea that she was at risk. However, she has a severe history of heart disease in our family, but no one had ever suggested to her that placed her at. So she didn't know to monitor. She didn't know, that she should be doing anything differently than she was doing. Although her dad had a heart attack in his 50s, her brother had a heart attack in his early 40s. She said to me, "Well, it just seemed like the men. It was the men that had heart attacks in my family. And whenever a man in my family died, it was hard. The men." Although her maternal grandmother, for some reason, this was 1997, it was never flagged for her. She was never said, never told some things to prevent this happening to you. Not that she was doing anything terribly wrong, but she wasn't doing things that we know now might have helped, like monitoring her blood work, etc. And we'll talk more about things you can do to be proactive. But just quickly, what had happened was she had a heart attack, and then she didn't recognize the symptoms, of course, because it wasn't agonizing chest pain and shooting pain down the arm, which is what we see all the time portrayed in the media as what a heart attack looks like, is how her male relatives had all experienced it. So she was at the mall on a Friday after work, and she felt a little one quick sharp pain in her chest, and then it passed. That can happen. And then she got home, and then she felt a sharp pain in her back. And then she started to feel nauseous, and she thought she was coming down with something, and her back hurt. And then she went and she laid down on the couch, and her husband came in and took a look at her and said, "We're going to the hospital because I think you're having a heart attack." Because looked like he was going through all his heart disease issues and his heart attack. He said, "You're completely gray," and that's what he looked like. So that's what he recognized, simply because he fortunately needed it. So they went to the hospital, and my mom was, they took her blood to do an enzyme test, but they also said, "It's wrong. It's not a heart attack. It's gallbladder. It'll be your gallbladder." And so they, sort of shuffled her off to the side, waiting for her blood work. And then her symptoms got more and more severe, and she almost died. And her heart was very badly damaged, and it changed her life from being very young and active 49-year-old to suddenly having a damaged heart for the rest of her life, and starting the rounds of so much medication and so on and so forth. Long story short, I'm doing my best. She, for the next 20 years, no follow-up. She did a cardiac rehab program immediately when she got out of the hospital. She said that was a little bit helpful, but it was a little bit mostly, it was 1997. She said she just couldn't find any information about what to do for herself going forward. And every time she tried to speak to her doctor, in her words, and she would say, "Well, I'm having chest pains. I'm short of breath. I have no energy." And he just she says, his response was to act like just anything to do with her heart. So 20 years she went on like that until finally her symptoms were getting so severe. I would see her. She was in Pictou County and I'm in Lunenburg, so we see each other fairly often. but I was here and, you know, she was suddenly like to walk from her car to a building, winded. And she had to move so slowly and she would get chest pain and she was taking her nitro spray all the time. And her nurse practitioner finally sent her for a stress test. She had a heart attack. She was having a stress test. She got sent through cardiology and they did an angiogram. The cardiologist walked in and looked at her and said, why haven't you seen me? Why weren't you here 10 years ago? Why didn't someone send you here? She said, I tried, but I tried. Get triple bypass. Within a few weeks, she started having chest pain. Where she lives, there's no cardiologist. The internal medicine specialist who she was seeing said, well, that's reflux. And said, just take Tums whenever it happens. So she spent months. This is within 6 months, you know, the 6 months after her triple bypass, with severe chest pains, fucking Tums. And she said she would try to sleep with a hot water bottle on her chest because her chest was so sore. And she called her nurse practitioner and said, anything stronger you can give me for this reflux? And she's the nurse practitioner again, said, that doesn't sound like reflux to me. Went with the cardiology, 2 out of 3 of her stents had failed. They said, if it's new sooner, might have been able to. So that's been sort of the history of her story. She did have another heart attack subsequently, number 3, and then number 4 when she had COVID last spring. At which point, I said, Dr. Mulvey, please, will you take my mom on? She needs someone who's looking out for her and who takes her seriously, taking my time, around her heart issues. And so now she's with Dr. Mulvey. I couldn't be happier. She couldn't be happier that she's finally, after 28 years of suffering and having really, I mean, she's had a happy life. She's here, but different than what she would have liked, maybe. Anyway, she's here. And so what I've learned, what this has meant for me, is I was 28, I think, when she had her first heart attack. And I learned from, I think it was my doctor at the time, I was living in Toronto for a few years, it was a young female doctor, and she said to me, this increases your risk. You have to be really on it. So I became proactive on it. And I started probably around age 30, having my blood work done every year. Even whenever, you know, if I moved or if I need a doctor, and I would say, yeah, I need my cholesterol checked. And they'd be like, I need my cholesterol checked every year. Here's why. And as soon as I tell them the history, now they go, oh, yes, okay. To the point that when I had my first baby and I went for my first OBGYN appointment, the OBGYN looked at my file and said, oh, you've done a history. Bad genes. But anyway, so at least I knew, right? And I ended up, so I lost weight, I became more active, I changed, I learned as much as I could, I changed as much as I could about how I ate, how I lived. I actually became a nutritionist and I specialize in heart disease. And I run and I don't smoke and I drink very little and I control my stress. I meditate, I teach meditation, I teach yoga, I tap dance, all the things. And still, like my mom, 49, 50, perimenopause, because, please correct me if I'm wrong, estrogen is protective against cholesterol. Suddenly your estrogen levels drop. It seems to not matter what you're doing, you no longer have that extra layer of protection. And so from my doctor saying things to me like, the best blood work I've seen in a month, and I wish my triglycerides were as good as yours. Suddenly, in 1 year, the next year, it was like, uh-oh, the receptionist is calling me and saying, you have to come in, there's a problem with your cholesterol. And my LDL cholesterol had and it was shocking. I mean, even though part of me expected it, it was shocking. So my doctor, thankfully, said, well, I don't know what to do with this, with your history. I'm referring you through the Women's Heart Health Clinic, which I'm so grateful that she was also proactive and took it serious. And so, you know, I said to Dr. Mulvey, what else can I be doing? should I not be running? Is that? And she said, no, there's every reason you should be running. So I run more and I tweak my diet more and I tap dance more. but I'm just trying so hard to be proactive and then I said, let me on this committee, let me help, let me tell people, like, please learn and, please learn your risk factors and know that so much cardiovascular disease is preventable to a certain degree. And so my mom and I wanted to come here today to say that, to say, be proactive, learn your risk factors, talk to your doctor, talk to your family if you have family that you can talk to about your family history, and then work with your healthcare providers. Go to the Wear Red Canada Day website. There's tons of resources there. Get active, change your diet, and just do all the things, because no one should end up like my mom with what happened to her. So I just hope that sharing our story today will motivate you, motivate anyone who's listening to this to be proactive and to be hopeful and to do whatever you can do to take care of your one precious heart. Thank you very much.
So I don't think that I need to say anything. Shannon has put it emotional. Thank you so much for so eloquently sharing with us the story of what can go wrong. Unfortunately, your mom's still here, and yeah, we're doing as much secondary prevention as possible, but as the role model for primary prevention, knowing the family history that you have, very important. So thank you so much, Shannon. That was a very powerful message. And we're going to follow up with you soon. Yeah. So, this is these slides, but they're all available online. And I think I just wanted to make a couple of quick points. And that was, as you see in this graph, Karen is in the red here. And this is to look at, like we were doing okay, chugging along, with heart disease, as far as in women, the mortality rates, they have actually risen. And if we look into the demographics, it's the younger women that tend to be getting more heart attacks. And there are lots of reasons why we could think about that. And one of them is just like, Shannon said, healthcare providers looked and said, you can't be having heart disease, you're too young, right? So, that is just it. The symptoms are not recognized in more than half of women. Women have those other symptoms more frequently, the discomforts that are elsewhere in the upper chest, back, epigastrium, stomach area, and have associated symptoms like shortness of breath, excessive sweating, pain that's just, it's excessive fatigue. It's difficult to figure out. Unfortunately, women are a little bit more complex. There's not so many guys here, so you're not all laughing. So that's but it is true when it comes to cardiovascular disease. We have to think more, and we have to think in different ways that we haven't been taught traditionally in medical. Because moreover, just beyond the presentation, is that they can be different in women. Is that the types of heart disease that women can have can be different too. Women can get all the same types, the blockage in the artery type that men get. They can get valvular heart disease. They can get a bunch of failure, other things that we're taught in medical school all the time. But more recently, we have discovered that women can get different things like SCAD, spontaneous coronary artery dissection occurs. 90% of the patients are women, and it strikes average age is about 50. So it strikes younger women. Vasospastic disorders, small vessel disorders, stress or broken heart syndrome, stress cardiomyopathy, that's actually older women, postmenopausal. Again, 90% of women with stress-induced cardiomyopathy, 90% of the patients that have stress-induced cardiomyopathy are women. So different things happen, and that is because the physiology is different in women, let alone peripartum cardiomyopathy, which obviously only women get pregnant so far. The thing is that even when we modify our risk factors, it's important to recognize that our risk factors are, but our risk factors that we think of the traditional risk factors, smoking, diabetes, high blood pressure, obesity, and high cholesterol, they are even more impactful, certain of them. Women that smoke are 2 times more likely to get a heart attack than men. Women that have diabetes are 3 times more likely to get a heart attack. And this is, so it's just not fair just for the traditional risk factors. So it's really important that we manage those. And then beyond that, women have more sex predominant. More women get rheumatoid arthritis and lupus. 2.5 times more women have rheumatoid arthritis, 10 times more women have lupus or systemic lupus erythematosus. And systemic inflammatory disease can increase your risk for developing atherosclerosis and blockages in the arteries. And then there are those that are very sex-specific risk factors that we never really recognized before. And that would be, as Shannon was clearly saying, you know, estrogen is protective when it's biologically in our system. And so women that have early or premature menopause, less than age 40, or early is in their early 40s, they are actually at increased risk because they don't have that protection anymore of the estrogen on their vessels. And not only just that they relax the vessels, but they also do good things to our lipids. They keep our LDL, the bad one, lower, and they keep our HDL higher. And then when that goes away in perimenopause, things can flip around as they did with Shannon. So it has to be monitored, it has to be treated appropriately. Polycystic ovary syndrome, those women are far more likely to have what's called metabolic syndrome, which is high blood pressure and cholesterol levels that are abnormal. And then the real, you know, stress test that we talked about, the coup de grace, so to speak, is the pregnancy complications. And for that, I'm going to ask our colleague, Dr. Anna Joust, to come and talk a little bit more in depth about our pregnancy-related risk factors as women and how they can increase our risk for cardiovascular. So what we can do about it. Anna, welcome. Thank you so much.
Let's go here. So my name is Anna Schaus. I'm an anesthesiologist. I work mostly at the IWP, but because of my additional expertise, I'm seeing women really at all stages of their lives. And so this has been my huge interest pretty much ever since I was a resident. And I'm so grateful for being invited quite a few years ago, I think it was 2018, that I have been at this event for the first time. And it's been absolutely amazing to see all of your energy and interest and advocacy, and Dr. Malbay and her team, amazing. So a huge honor to be here and tell you about my favorite topic, medicine, which is heart health and pregnancy. So women's hearts do many amazing things, but one of the amazing things they do is support the development of the. There are some very profound changes that happen during pregnancy, and these can range from increasing the total blood volume to increasing actual heart. So the heart muscle actually.
Unfortunately, I can't get it to work, so don't worry.
Let's see. It increases. The heart actually grows more muscle in pregnancy so that it can pump about 50% more blood volume. So these are absolutely profound changes. And on top of that, we have widening of the blood vessels. So you can imagine that this really shifts the whole balance of the cardiovascular system. And this really messy graph sort of shows the extent of these changes, where the main axis is the non-pregnant state. So this is huge. And in fact, some of the changes have been found to be similar to those that we see in endurance athletes. I don't think this will be a surprise to anyone who's ever been in some ways a similar sport. Well, some of the changes, remember, resemble some of the disease states, but they are not harmful. And in fact, remarkably, all of the changes reverse in weeks to months. Yes. Everybody hear me okay? So because they're driven by hormones, they don't tend to cause any harm. Now, to understand how this all works, I will present to you a concept. And again, it's just the concept, but it's a very useful one to think about a lot of things that have to do with cardiovascular health. And this is the concept of physiologic reserve. So physiologic reserve is essentially this extra functionality in our system that we have available to us to do not everyday things, but things that are like, for example, if you were to break into a sprint to catch the bus or run away from a saber-toothed tiger, these types of things. So it's an evolutionary concept. It's present across all systems, and it actually is very applicable to the way we are starting to think about women's cardiovascular health now, which is sort of more of a life course. So we all start with a certain amount of physiologic reserve. It tends to be at sort of between 20 to 30 years of age. And for the most part, this still overlaps with usual time women tend to become kids. And then over the course of life, there are certain stressors that happen, and they sort of cause this little dip in your physiologic reserve that for the most part, people tend to bounce back from. Now, how quickly and how much they actually bounce back from things has to do with something called resilience. And this resilience may have to do with genetics, it may have to do with private health, but a lot of it is actually social circumstances as well. How much financial resource we have to restore ourselves back to health, the healthcare system. So a lot of things play into this, which makes it very useful as a concept. So because it declines over time, and it tends to peak at around the time of childbearing age, pregnancy actually really tests the depths of this physiologic reserve. And so even though people, when they're young and healthy, they tend to bounce back okay, occasionally this stressor dips the physiologic reserve below a certain line, and below that certain line, and so what happens when the stress test of pregnancy uncovers a problem? Well, it's not surprising that women who have pre-existing conditions will tend to have problems in pregnancy when all of these changes take place, because there may be a decreased physiologic reserve to start with. But it's also very common to see women who present in pregnancy for the first time with an underlying. And then there are exclusively pregnancy-related problems, which affect about 2 to 8% of women, and potentially preeclampsia, cardiomyopathy, which is basically a decrease in gestational diabetes. So in Nova Scotia, this is about 500 women every year. So this is very common. And in fact, if you look at the entire life course, you can see that even though maternal health usually stabilizes after pregnancy, there may be something related to a lot of these conditions that actually lead to in fact, epidemiologists starting in 2000s have recognized that women who have certain problems in pregnancy, I think this initially started with preeclampsia, have an increased risk of cardiovascular problems later in life. And the magnitude of this increase could be anywhere between 2 to 4 times, so not insignificant. It affects the increased risk of heart attack, cardiovascular disease, stroke. So not only do they have an increased risk, but these problems tend to happen to them earlier in life. So this premature cardiovascular disease is what makes their physiology actually in the talking of disease very similar to. So now we know that it's not just preeclampsia, but a multitude of other similar conditions that can crop up in pregnancy that convey this high risk. So it could be preterm delivery, small baby for gestational age, preeclampsia, hypertensive disorders, gestational diabetes, and then also infertility and infertility treatment. And when we start with those risks, and then on top of that, we add the traditional risk factors, there are some aspects which are cumulative, so these all add up, but also it affords this enormous opportunity to address the traditional risk factors. So by identifying women who are at high risk to start with and working really hard to address these factors, we I'm absolutely certain. There's a lot of work being done, a lot of research coming out. In fact, knowing that 50 to 80% of cardiovascular disease, even in women who have had all of these problems in pregnancy, can be traced back to the traditional risk factors. Allows us to do things like what you've been hearing about if you've been coming to Wear Red Day: eat better, exercise, stop smoking or don't take up smoking, manage the weight, control blood pressure, blood sugar, and cholesterol. So deal with all the things that can chip away at that physiologic reserve and cause this increased rate of its decline. So some years ago, we interviewed these amazing women who have had their lived experience of pregnancy and intention. And they told us in no uncertain terms that motherhood was so demanding, they had so many competing priorities that their health was really at that very moment not at the top of the list. But at the same time, they told us that they have this really increased motivation to change this, to change things and change their lifestyle and address these things. So having a new baby is a huge motivator for lifestyle change. But they encountered barriers, and these had to do with their healthcare provider knowledge. People just did not know. They also didn't know themselves. So there's really low level of awareness among patients, but also healthcare providers about all. They also didn't have adequate supports, quite honestly. And this is a big issue for us as we try to revamp our healthcare system. And then early screening, implementing healthy lifestyle changes, factors that can and will work. One of the things that has come out recently is something called a pregnancy passport. So it's one of those tools that can probably address a number of these barriers. And it was issued by the International Society of Obstetricians and Gynecologists. And essentially it's meant to be collaborative. So the woman will look at it and go through it with their healthcare provider. It's meant to be informative, so it provides information about their risk factors, but it's also actionable. So it tells you things that you can actually do to deal with things. So it's also goal oriented. So, you know, if you're identified as somebody who's at risk of having high cholesterol, they will tell you what your target is and how often you should have that in. So in other words, it fosters self-management, which is another big thing that they wanted. They wanted to have their own health history in their hands, and they wanted to be empowered to do that. So I would like to leave you with a few take-home messages. And you weren't here, so you are already aware of all of this, and you are, I feel, not the crowd that we need to talk to. But adverse outcomes in pregnancy basically present a window into future cardiovascular health. So it's an opportunity, it's a huge opportunity to address modifiable risk factors. And all of the things you've been hearing about that we know work will also work for these women. So lifestyle changes, early screening for cardiovascular and metabolic can and will reduce the risk for heart attacks. So just imagine if we address things early, like Dr. Mulvey said, in high school, how much better. Thank you so much for being here. Thank you for your advocacy.
That is a really on target message. And refocus on prevention today and the awareness of heart disease in women and how to be empowered, how to be able to take things in your control and what you can do. So this is kind of a little bit of a summary slide to put it all together, 80% preventable really, but there's that other 20% that is like family history, there's other factors that can't really pin down maybe what they are, but we often can if we just know the family history, then we can look into the cholesterol details more, for example. But be active, eat a variety of foods, don't smoke, limit alcohol, have a healthy body weight, get adequate sleep is a new one that also seems to be a significant role in prevention of cardiovascular disease. And know your numbers, right? Get those checkups to know your numbers, the blood sugar, the blood pressure, and your cholesterol levels. And there's more than just the cholesterol levels. People that have a very strong family history ask to have your LP little a, lipoprotein A. This is another marker that we are learning about with time. So I would just leave you with those quick messages and recognizing on top of it, if you're a woman, know everything that Anna has told you today. If you have a history of preeclampsia or gestational diabetes, you really have to get on top of your modifiable risk factors because that's a marker. So now the fun part begins. All right, I'm going to ask Penny, could you come help me with this, please?